Dzień dobry Państwu bardzo serdecznie, witam. Dziękuję Michał za bardzo miłe wprowadzenie. Już tak odsuwam się tym krzesełkiem, bo ten panel będzie trochę na zasadzie, mam nadzieję, sporu, czyli kto jest za, kto jest przeciw, dlatego obawiam się, że będą emocje, więc ja już chciałbym być z boku.
Będzie podział na scenie, kto za, kto przeciw?
Tak. Mam nadzieję, że będzie taki podział. Będziemy się spierać, tak jak Państwo widzicie, będziemy rozmawiali o tym, czy CAR-T, czy przeciwciała bispecyficzne, doświadczenia, wyzwania i przyszłość immunoterapii komórkowych. Panel będzie w języku angielskim, ponieważ mamy gości zagranicznych. Najpierw zaproszę może na scenę polską stronę, pani profesor Lidia Gill. Jest pani profesor?
Możliwe, że pani profesor jest w drodze, więc jakby coś pani profesor...
Ja rozmawiałem z panią profesor, była na scenie z całą pewnością.
My zaraz spróbujemy znaleźć panią profesor.
Pan profesor Dominik Dytfeld też na pewno był. Chwalił się muszką przywiezioną prosto z Orlando, więc na pewno też jest.
To Krzysztofie wprowadzaj, a ja wobec tego spróbuję dla państwa znaleźć ekspertów i za chwilę w komplecie zameldujemy
Szukamy
się.
ekspertów. Pani doktor Charlotte Peulin jest. You are the very first one. Please take a seat. So the choice is yours. Okay. Taking the sense. Okay. I pan profesor Hermann Einzele. Idzie. Dzień dobry. Hello. Good afternoon. Idą już państwo Polacy. Hello, professor. Good afternoon. Dzień dobry pani profesor. Dzień dobry panie profesorze. Ojej. Okay, so now I will switch to English. Szanowni Państwo, oczywiście kto jeszcze nie wziął słuchawek, to bardzo proszę o słuchawki i możecie Państwo słuchać tłumaczenia. Jeżeli chodzi o nasz panel, to ponieważ goście są ze strony angielskiej, zresztą będziemy mówili po angielsku. Good morning everybody. I'm very glad that we'll have this kind of topic. Welcome to Poland. Welcome to Poland, Charlotte. Welcome to Poland, Herman. Let me introduce our guest first. Dr. Charlotte Peulin is from UK. She's working for Cancer Research UK. She's clinician, scientist, and team leader at the Institute of Cancer Research, and also the consultant hematologist at the Royal Marsden Hospital in London. Good afternoon. Tell me, what's the weather in London today? Is it better in Warsaw or worse?
It's very similar to Warsaw.
Oh yeah, so okay, that's good. Okay, how about the weather in Germany? Professor Hermann Einzele, he's professor of internal medicine and director of the Department of Internal Medicine at the University Hospital of Würzburg, Germany.
Exactly the same.
Exactly the same, okay. I hope that there will be much more differences in our topic, not about the weather, okay?
And generally much worse than in Orlando.
Okay.
We just came from a meeting in Orlando.
I bet in Orlando is sunshine, I think. Professor Lidia Gill z Poznania. How is the weather in Poznań?
So the weather is just like in Warsaw.
Just like here, okay. No differences. Pani professor, okay, sorry. Professor Lidia Gill, she's a head of clinic and hematology and bone marrow transplantation at the University in Poznań, and she's managing the top one clinical center for CAR-T in Poland. And Mr. Dominik Dytfeld, Professor Dominik Dytfeld, also from Poznań, but I think that straight from Ash. Concerning
we all are straight from Ash. All of us.
Oh,
yes.
It was supposed to be a very good airport party and very good. Yeah, very good connection from Ash. Okay, Professor Gill is a founder and president of the Polish Myeloma Consortium, and also is working in the department. Dytfeld. I'm sorry.
It's okay. We worked together for like 20 plus years, so
yes. I don't know.
Our genotype is even mixed, I think.
Okay. So let's say that our discussion is supposed to differentiate between CAR-T and bispecific antibodies. So maybe at the beginning I will ask you it's something, because there's a very old Polish joke. Przychodzi baba do lekarza. All of you for sure know this joke. So let's say that there is przychodzi baba do lekarza it means that there is a lady coming into the cabinet of the physician, let's say. So let's say that there is a lady coming into the cabinet of the physician with myeloma, and the doctor says, CAR-T or bispecific? Okay, who first? Maybe Polish side. Pani professor. Okay, pan professor. Professor Dytfeld, what would you say to this lady who's coming with myeloma to your cabinet?
Well, in general, since I work in Poznań and we are the CAR center, I mean, my answer cannot be different than to say CAR-T. But
CAR-T.
honestly, there are several arguments to use CAR-T as a first choice. First of all, I do believe that this is the most effective treatment in myeloma. Maybe there will be something better, maybe there will be something more effective and less toxic, but so far we know that CAR-T and myeloma are the best. That's first. The second advantage of CAR-T is that this is once and done. So you give the cards and the patient is free of the treatment. We don't have that many patients with myeloma after CAR-T, only in CARTITUDE-4, CARTITUDE-5. That's for you, Herman, for you. We don't have access to CAR-T yet in myeloma. But all of them, all patients keep saying that this is the best time in their life after diagnosis of myeloma. So the disease is under control and they are free of the treatment. So I have two arguments for CAR-T.
So let's argue on that later on, but Professor Gill, what is your response to this
So
lady?
that's absolutely the same, just like Dominique. So
No,
we
you
work
have to
together and
differentiate somehow.
we have the same. We have the same. Yes, the same dream also, because we do believe that CAR-T cell therapy probably, maybe, I hope so, will cure the patient with multiple myeloma. We have a number of very modern and effective treatment, but we still cannot cure the disease completely. That's why we do believe that it is maybe the role for CAR-T cell therapy.
Yeah, but honestly speaking, CAR-T is not reimbursed in Poland yet.
Not yet.
So for today, for the patient, you have to say bispecifics.
Or clinical trial.
Or clinical trial. Okay, sure, doctor. UK.
So I am going to give an alternative view, not just because it will be more interesting. I am also excited about CAR-T treatments, and we also do not have these easily available in the UK, only through clinical trials or through private healthcare at the moment. We do have good access to bispecific antibody therapies. And for me, there are many advantages to the bispecific antibodies. They are available straight away. We do not have to wait for them to be manufactured. They are suitable for more patients, so it is probably more feasible to give bispecific antibody therapies to older and more frail patients than to deliver the current CAR-T cell therapies that are approved. We hope in the future the newer CAR-T therapies will be more easily tolerated by patients, but the ones we have available at the moment I do not believe are suitable for all older, frailer patients. And my third point is that we have really exciting data from just last week about the amazing outcomes from the MajesTEC-3 trial, which looked at bispecific antibody teclistamab combined with daratumumab in patients who have had only 1 to 3 prior treatments. And this showed an amazing improvement in both disease remission time and also overall survival for patients. And to me, that data looks as good as the CAR-T data in a similar line of therapy, if not better.
Okay, thank you very much. And the fourth one, kind of answer. What is your suggestion to the patients?
So we are in the lucky situation in Germany that we have full access to CAR-T cells and bispecific antibodies. And in my unit, we do about 100 to 120 CAR-T cells per year. And the oldest patient that we actually did was 84 years old. And now looking back to about 10 years of CAR-T cell therapy, in the beginning, we had nearly every patient on the intensive care unit because CRS, ICANS, and everybody was extremely scared about what could happen after CAR-T cell therapy. Now we admit the patient only for a few days, and it's really a very easy treatment. And I must say, as my Polish colleagues have confirmed, the patient like the treatment because it's a one treatment and then they are treatment free often for years and they have an extremely good quality of life. But there are certain also toxicities associated. One is the late neurotoxicity, which one has to be aware of, but I think with new strategies of managing this can be done. And in addition, I must say, also coming back from the ASH, there were fantastic presentations about bispecific antibodies in combinations, now moving to earlier lines of therapy. But I don't think it's such, I think it's, what I wanted to transport to our patients is that we are lucky that we have so many new options now. And I guess if we have both available, we would probably do CAR T cells first, because you can actually treat a patient who is relapsing after CAR T cells very efficiently with bispecifics, versus if you start with a bispecific, you might have problems then to generate CAR T cells. So from the sequencing, I would do the CAR T cell therapy first, but maybe the bispecific and bispecific combinations will be so potent that we actually don't need the CAR T cells anymore. So I think it's a race between bispecifics and CAR T cells, but I think it's really good for our patients that we have so many, so fantastic, efficient treatment options now.
Yeah, thank you very much. As you mentioned, both kind of therapies are quite new, emerged in a late few years, and they are both just now started to score clinical results and publication and so on. But we already started to notice the first data about efficacy of both. So maybe first question: what is the efficacy of CAR T? Professor? Who would like?
Me again?
Professor Dytvo,
Okay,
please.
so the results are amazing and never seen before. For patients with advanced disease, the overall response rate is reaching 100%, complete response rate is like 80-90%, so something that I have never seen in my life. That's one thing, but there is something more. Actually, I don't have this slide, I can see it in my mind now. Overall survival, so the time of survival of patients after CARTITUDE-1 study, when the CARVYKTI was used in patients with very advanced disease after 5 lines of therapy, so very, very advanced disease. And there is something like the plateau that you may see, and those patients may be considered as functionally cured. So I know that the saying that there is a cure for myeloma, it's maybe too early, but I think they are the candidates for that. And I think that, as I said at the beginning, the efficacy is extremely high, reaching 100% of patients. The efficacy of bispecifics are a bit lower. However, as it was shown in the MajesTEC-3, when it was combined with daratumumab, the results are kind of similar to CAR T. So probably the bispecific being used as a monotherapy is not good enough. There are studies combining bispecific with several other drugs, so I do believe that the efficacy of bispecific should be considered as a set with other drugs. So as of now, again, I do believe that CARs are the number one, but the bispecific may change it much, much more, being given in the first-line treatment and so on. I do believe there is MajesTEC-7 study testing the bispecific in the frontline, both teclistamab and talquetamab. The bispecific are being combined together with the RediREX study, and also in Poland we have the TITAN study when both TEC and TAL will be used as a monotherapy, as a maintenance study. So the race is on. The race is on. But again, as I said, now the CAR T, in my opinion, are the best.
Professor Gil would like to add something. Maybe
I,
about your experience concerning leukemia in Poznań as well.
In lymphoma, maybe more, because we have about 200 patients after treatment with CAR T cell therapy, and we all have experience, I think, in this field. But I would like to to say something about safety of this treatment.
That was my another question.
And
Maybe let's
okay,
focus
the next.
about
Okay,
efficacy first, okay?
So this efficacy for patients treated because of non-Hodgkin lymphoma is really very high. There are some subgroups of patients when we observe response rate on the level of 80-85%, and those responses are durable. So we do believe that those patients who responded to treatment, to CAR T-cell therapy, and after 2 years they keep they maintain complete remission, they are completely cured from the disease. So this efficacy is really very high, and the rate of complication is really very low, just like Professor Einzel told. So it is really, from my perspective, a very safe treatment. So I always, and I think that Dominic too, we do look at this treatment as transplantologists. So we do this cellular therapy for years, and that's why this treatment seems to be more safe and more effective than stem cell transplantation, autologous stem cell transplantation.
Charlotte, a few words more about the CAR-T or maybe the efficacy of bispecifics.
So I think I agree with everybody. The efficacy of CAR-T is really high. We have seen really amazing results, and I agree that the data from the long-term follow-up of the CARTITUDE-1 trial looks like there are a number of patients who have stayed in remission for a very long time, perhaps will reach a functional cure. I still think that as we evolve data, I think the race is on is a good expression. I think as we see more and more data come through about both treatments, what we would like is for both to be very effective and equally available and equally deliverable. And I guess that is the challenge in some ways. We are perhaps going to be limited by the ability of the number of centers and beds and slots that we have available to treat all patients with CAR-T, and for some bispecific antibodies may be a preferable choice, for some CAR-T may be a preferable choice, and wouldn't it be great if we had the option to pick for the individual patient in front of us?
Professor, what's your opinion about that? Shall we differentiate a group of patients, first choosing CAR-T or bispecifics, or just go on sequencing?
Yeah, so I would agree with my with the previous speakers that there is a certain patient population that might not be suitable for CAR T-cell therapy. So, for example, a patient who has a reduced renal function, I would be kind of hesitant to put this patient on a CAR T-cell therapy. Also, patients that have already neurological issues, that have cardiac or pulmonary dysfunction, these would not be ideal patients for CAR T-cell therapy. So a second patient population where I would be also hesitant to really think about him or her to go for CAR T-cell therapy is a patient with a disease that is difficult to control, because currently it takes about 6 to 8 weeks until we have the CAR T-cells available, which means that we have to control the disease in this specific patients for at least 6 to 8 weeks. We now use bispecific antibodies for this kind of bridging therapy. This can actually improve the situation. But in the past, we had about 10% of patients that, in spite of having the T cells taken and the CAR T cell production already ongoing, didn't make it to the CAR T cell reinfusion because of the rapidly progressing disease. So certain organ functions and also the aggressiveness of the disease could be factors that might actually prevent the physician to actually go ahead with CAR T-cell therapy. With bispecifics, the infection risk is higher than with CAR T-cells. So in patients that have a very high risk of infectious complications, I would be kind of hesitant to put him at least on a BCMA targeting bispecific. There are other bispecifics targeting GPRC5D which are not inducing the same risk of infection. So I think it depends on the patients, and it's nice to have different options.
Do you think that we will go into direction rather of building the sequence, the optimums of sequencing, or making like one nil choice, whether this patient is for CAR-T and that's all?
So some patients will probably never be a candidate for CAR-T
Okay.
cell therapy. But
And
others...
an approximate number, 10%, like you said?
I guess there's more.
More.
A lot of the elderly myeloma patients are not candidates for CAR-T cell therapy. So we did an 84-year-old one, but I think at least when a patient is beyond 75, I would really consider the patient whether he's really fit enough to go for CAR-T cell therapy. So a lot of patients will not qualify.
Professor Gill wanted to...
I was just going to say that that is half of patients.
Yeah.
So half of patients are aged around 73 or over. So
But do you agree with this age level?
I think I entirely agree that we would never set an age, and that is not what Professor Einzeley was saying either, but an age above which you would have to be very more careful in terms of the full assessment of patients and who was suitable to undergo the procedure.
Professor Gill?
So, of course, there are patients older than 80 who were treated with CAR-T cell therapy, but we should be very careful with this group of patients. Professor Einzeley mentioned about infection. A few weeks ago, I've been in your city, in Würzburg. It was Infectious Diseases Working Party, EBMT, yes, and I had a lecture about infection complication after bispecific antibodies, and this is really problem more in multiple myeloma than in lymphomas. So it is also a problem after CAR-T cell therapy, however, not so severe.
Professor Dittfeld, on that topic?
I cannot add anything more.
Please disagree with anything.
Okay, no. It's really hard. I mean, you are in the line, we had the same actually comments and conclusions. There is a population of patients that are not eligible for CAR-T, I agree. However, when compared to that auto-transplantation, the limit is lower, so, even older people, people who are not qualified for transplantation can be eligible for CAR-T. So that's one of the conclusion. But yes, there's also, certain disease. There are certain group of patients that they have aggressive disease. What Herman just said, that they cannot wait for the CAR. So those two group of patients may not benefit from CAR-T. But elsewhere, I would consider at least as a first choice, as I said.
Okay, so let's go to another topic. The safety and toxicity management in applying both therapies. I found few publications then quoted that CAR-T has the higher cure rate, but the lower toxicity and lower toxicity. Is it true, or is it just the tendency?
No, it depends. It depends. Even the best drug has his own, gray zone. So the toxicity. As Herman just said, there is a neurological toxicity in CARs. Delayed and severe, and some of our patients, even in Poznań, experience that, and this is really hard to treat and how to explain to patients why it happened, what happened, and how can be managed. And in one patient, we have the Parkinsonism that wasn't cured at all, and that's extremely difficult. And I do believe that's the most challenging part of the CARs. The cilta-cel. So that's the neurotoxicity, and I do believe that's the major limiting factor in terms of the development of that therapy. And in terms of the infections, there is also some, but as Lydia just said, there is much more infection in the bispecific, especially in myeloma, as we're discussing now. So each of the treatment has its own specific toxicity. So CARs, I do believe that the neural toxicity and bispecific, the infection.
Professor Gill, how about CRS?
So I must say that both therapies, B-specific antibodies and CAR T-cell therapy, those therapies are T-cell directing or directing therapies, so they have very similar profile of toxicity. So CRS and neurological complication are observed after both forms of treatment, and but with different accents. So after CAR T-cell therapy, more CRS, more neurological complication, and late neurological complication, which is an issue, I think, and we think all over the world how to prevent it or how to treat it, and this is observed not after all, after only selected CAR T-cell, I can say. But after B-specific antibodies, more infection, from my opinion, and also from our observation and everyday practice, because we do have access to B-specific antibodies, and we know how those patients do on the treatment.
Do you think that we can learn more and be better in treating the side effects?
So we are already learning a lot about how to manage the risk of infections. So when we first started in the first Majestic-1 study, we saw a lot of patients having infections, but then we understood from this and from other trials that using preventative immunoglobulin intravenously or subcutaneously, which is an antibody replacement therapy that can be administered to patients once a month. This can really reduce the risk of severe infections, and using appropriate tablet antiviral, antibacterial approaches as well can be very helpful to reduce the risk of infection. But I think, as we've alluded to, not all CAR T cells are the same, and not all bispecific antibodies are the same. So the GPRC5D and bispecific antibodies have a lower risk of infection, and we are seeing newer CAR T cell therapies that seem to have a lower rate of the neurotoxicity that we have been talking about compared to cilta-cel, which is the kind of most widely available treatment. And so hopefully, for both treatments, these risks will reduce over time.
Professor, can we combine the, for example, age of patients with side effects, different types of side effects? Do we have any other possibilities of differentiate side effects before curing the patients?
So a very important issue is the disease control prior to starting a T-cell based therapy. So if you put a patient on a CAR T-cell therapy who has still a very high tumor load, the risk of any complications is much higher when compared to a patient who you have a good tumor control. And the same applies also for bispecific antibodies. If you go in with a bispecific in a patient who has a very high tumor load, the risk of CRS and ICANS is much higher when compared to a patient who is in good control. The second thing is, what we increasingly learn is that in a patient who has a very rapid proliferation of CAR T cells, or also T cells following bispecific antibodies, that means you have a very intensive immune stimulation, that these patients are also at a higher risk of developing complications. So for example, after CAR T-cell therapy, we have now started in a patient who has a very rapid proliferation of cells to go in with steroids to kind of dampen the increase in the T cells, which can also help to reduce the toxicity. And furthermore, there are things like tocilizumab, dexamethasone that is used to treat these complications. And for infectious complications, Charlotte has nicely pointed out that immune globulin infusions, intensive monitoring, also being aware that some of these patients might actually get very rare infectious complications. For example, now at the ASH meeting, it was reported that CMV infection, an infection we just know from the allogeneic stem cell transplantation, is occurring after CAR T cells or bispecific. So also to be aware of rare infectious complications is very important.
Professor, you wanted to add
So,
something?
yes, I think that in this, because of infection complication, this education of patients is not only this knowledge for us, but also education of patients and families is extremely important, because it is especially in patients who are treated with B-specific antibodies, they are on treatment for longer time. So to avoid infection, this knowledge is very important, prophylaxis of course, and knowledge. Education.
And one more issue, if we use sequencing, I mean bispecifics and then CAR T or otherwise, are those side effects just simply multiply or not? Do we know it?
I think you would never give CAR T cells directly after a bispecific or vice versa. So you would normally wait for a certain time until the side effects of one treatment has actually gone. But you can actually sequence, but it's always good if you sequence that you wait for several months before you actually go in with a new T-cell therapy. Not also because of toxicities, but you also have often an exhausted T-cell repertoire. So if the T-cells are exhausted, you cannot generate good CAR T-cells, and you cannot actually get a good response to a bispecific antibody.
Professor Duttfeld, what's your advice for patients who are now being treated with bispecifics? Are they ready to switch to CAR T, or does it make any sense with this approach?
Well, so as Herman just said, we shouldn't use this treatment one after another, because we are using the same stuff for killing the myeloma, so lymphocytes. They are all mobilized inside the human body by bispecific, or regenerate outside the human body by giving this artificial receptor. But at the end of the day, they will do the same job. So if they are exhausted, they are not able to kill. So that's why it should be. Well, in Poland we have this relatively difficult situation where it could be worse, of course, but it could be also better, because we have access to actually all bispecifics, and we have no access to the CAR T.
But let's hope that it
Yeah,
will
we do believe that
future,
next year we will have in the spring both the Carvykti and Abecma. We do
and
believe.
then what?
Well, so again, as I said, the first choice will be the CAR T as the beginning, and then just have in mind that, if you prepare the CAR T, you take only a piece of lymphocyte from the human body, and they are being re-engineered and then put back. Why? By using bispecific, you are using the whole lymphocyte that are in the human body, and based from that, you are not really able to produce effective CARs. So again, the CARs, that's another argument for the CARs as a first choice, because, it's better to use the bispecific after CARs than opposite. Agree? Yeah.
Any
I
comments?
agree. I guess the only thing I would say is that in the UK we also don't have access to CAR T yet, but we hope to have it sometime soon. And a lot of patients say, should I not have bispecific antibody today because I hope to have CAR T cell therapy next year? And my answer to that is usually you should always have the best treatment that you have available for you at this time. So I do not believe in waiting for the hope for a future treatment and therefore having a less good treatment now. So if the treatment that is available in Poland and you needed a new treatment quickly, then bispecific antibodies are very excellent and can work very well. So it is not a good idea to wait on the uncertain promise of a future treatment.
Right. So those sentences I have in my mind. So directly you read it from my mind in English, but because I agree absolutely in the same way. What we are doing now, hoping to have, I don't know, maybe it's not a good approach, but because we have two BiTEs, I mean the GPRC5D and the BCMA, so we are rather preferring to use talquetamab as the first choice, saving BCMA for the CARs. I mean, that's what we are doing. I don't know, it's a good approach, but that's what we are doing.
Don't wait, take the medicine, yes?
Because you don't know what's going to be tomorrow, you have to have the best choice today. And you cannot plan the treatment in that way. The best what is available today.
Okay, any comment, Professor, on that?
No, I think that's a very good strategy, and I think that one of the issues with the bispecifics that you are losing the target antigen. So, for example, if you give a BCMA targeting bispecific, there is a risk of about 50% that after maybe a year or more than a year of treatment, the myeloma cell have no BCMA on the surface anymore. So no new treatment would actually be able to target the myeloma cell again. And therefore, what Dominic actually just indicated, that using GPRC5D and leaving the option open for another BCMA-targeted therapies makes completely sense.
Any comments on that? Because I would like to ask the last question concerning the quality of life of patients with being treated both therapies, because we have one time approach, one incision, or being treated, well, over time, just without end. What is the difference with your perspective? Does it make any significant change?
So I think we would like to move towards all patients being off treatment in remission. That is what every patient would want, and we as hematologists would want to aim for in patients. Whether we can do that through CAR T-cell therapy or through a limited time of bispecific therapy are two different approaches to trying to achieve that. But I think I agree that patients broadly like to be off treatment. I think the only thing I would say is that although we think that that is the case with CAR T, it's not entirely the case. Patients still need to take maybe preventative immunoglobulins or preventative other tablets. So it is hard to say they're truly off therapy completely. And the actual administration of the bispecific antibody over time is generally given less often, so perhaps once a month or once every 2 months after a while. So it is not lots of visits to the hospital. So I agree that broadly CAR T gives the better option for being kind of off treatment, but the bispecific antibodies also give a close, almost close to that option.
Professor Gill, one time infusion or multiple infusions?
I would like to share with our experience concerning lymphoma patients, but also published data, because CAR T-cell therapy was compared to autologous stem cell transplantation, not only in the context of efficacy, but also quality of life. And it was proven in phase 3 studies that the quality of life is much better. And the same confirms our patients. So this quality of life is really much better. If I could compare it to be specific, in lymphoma it is a little bit easier because most of therapies, also we do have therapies which are limited in time in multiple myeloma. Unfortunately, this is long-term treatment up to progression or intolerance. So that's why it is a little bit more complicated. But generally, quality of life, our patients after CAR T-cell therapy is really very good.
Professor, any comment on that? May we expect that this bispecific treatment will be in some future just limited, that it will be ended up and waiting for any progression or just observing? Can we expect that?
No, I think what Lydia just pointed out, that in lymphoma people are giving the bispecifics for a limited time period makes completely sense. I must say, we did the first treatment worldwide with bispecifics in my department with blinatumomab, and we never gave blinatumomab until progression. We always stopped the bispecific antibody, waited until the disease came back, and the patient again very nicely responded. And we had patients with 3-4 relapses, and we were always able to control the relapse again with a bispecific antibody.
Is that standard approach, or is just your approach?
No, I think that's a standard approach. And I think in the lymphoma, as Lydia has pointed out, they are all, nearly all the bispecifics, they're giving it for fixed duration. Now in myeloma, I think the issue was always that we thought that we need continuous treatment because the diseases can be so aggressive. But I think they are all already the first protocols actually using bispecifics also in myeloma for a limited time period. So I think we are learning from the lymphoma people.
Okay. Do you think I would like to end this discussion with some financial and logistic issues, because as for now, CAR-T are rather expensive, and shall we expect that it will become cheaper and cheaper? For example, I read a few months ago that there is already a robotic procedure of preparing CAR-T. It makes 74% cheaper and much faster. Can we expect that this timing, 6-8 weeks, will be much shorter, which will help patients? Was it any discussion about that on ASH?
No. I mean, gentlemen, they do not talk about money that
Oh,
much.
come on. Of course
But
they do.
no, I know. So, well, like with every technology, there is an improvement. And I remember that, working with Yescarta or Kymriah, we were waiting for longer than months. Now we are waiting for this for much shorter time, 3 weeks, for example. And I
2
do believe,
weeks. So for
the myeloma, I think it will be the same. But talking about the money, talking about the cost, I know that CARs looks very, very expensive, but when you count, for example, for like 2 years bispecific and 2 years of the care of patients after CAR-T, again, once and done, 2 weeks of hospitalization, and then the patient is free of the treatment. When you add all this hospitalization that are necessary for infuse bispecific and also cost of the drug, I don't know what is more expensive. So at the end of the day, I think that CARs will be cheaper, even compared to the bispecific, even now.
Do you agree, Professor Gill?
So yes, I do agree. However, I think that development of academic CAR T-cell point of care CAR T-cell therapies will be maybe in the future can solve the problem of financial problem issues. And also time to have access to the product will be shorter. I think so. I hope so. But Dominic, a few hours ago we finished our conference on from standards to experiments in hematology in the perspective of ASH 2025. And Dominic presented data on in vivo CAR T-cell, so it may be something very interesting for the future. First in human.
Tell us something.
Yes.
The idea.
Yeah, so that's the late breaking abstract. That was I think the most important presentation.
3 patients as for now.
Four
patients.
Four. And all they achieved, and this is something like, like bispecific and CARs in one, because, it was given IV. There was no this taking cells, manufacturing, freezing, thawing, saying back, and all that operational issues, which will not be an issue in the way. And also there is no lymphodepletion needed for that. So I think that will be the solution for that in the future.
Tell us more about this LV. What is the idea, and where is that experiment taking place?
This one, what
yes,
I said,
yes.
that was the study was in my car. That's the name of the study. It was made mostly in Australia. I think only in Australia. Am I correct? In Australia, I think. And again, the 4 patients were infused. Phase 1 study, 3+3 study design. All patients achieve MRD negativity. And no neurotoxicity. And, that may be the next step.
Charlotte, any comments on that? Because we
I
discussed
guess
about that before.
Just to maybe explain for people in the audience who are maybe less familiar. So the idea is usually with the CAR T cells that we administer at the moment, we have to take T cells out from the patient, manufacture the CAR T cell, which is a process that takes maybe 6 to 8 weeks to have the cells then available to go back into the patient, so the same cells from the same patient back into the patient for the treatment. Whereas when we say in vivo CAR, that means we are not doing any of that process. So we do not have to take the cells out. Instead, the material that helps to change the T cells in the patient's body into the targeting T cell specific for the myeloma happens all within the patient. So there is an injection, and then that whole manufacturing process, if you like, takes place within the patient's body. So for me, this is an amazing alternative way to give this CAR T treatment, because it saves not only the time of manufacturing, but also in order to give back those manufactured T cells that have been made outside of the body, we have to give some chemotherapy before we give them back to the patient to reduce the normal T cells and let the newly made T cells take over. Whereas in the in vivo approach, this new way of doing it, we do not have to do that. And there are some side effects of that chemotherapy, low blood counts over several weeks or months, and increased risk of infections, possibly increased risk of second cancers in the longer term, that make this approach where we don't need to do any of that really exciting in terms of potentially reducing the side effects that we see.
But would this approach work with all patients or any specific type of ones? You don't know.
I think because
Well-
only 4 patients have been treated, it is hard
Yeah,
to
but
say.
they've been kind of selected, yeah?
The last one got the treatment like a month ago, so just wait for that.
But I think some
Too
of the
early.
same considerations that Professor Einzeley was talking about would apply. So this would presumably not be a good treatment for patients with a very high burden of disease, a lot of myeloma at the time that they were having the treatment, because it would take some time for the CAR C cells to develop in the patient.
Professor Ainsley, comment on that. Do you think that this is going to be future or just an experiment?
No, I think there's really ongoing research and the ongoing clinical trials. There were actually already a paper out a few weeks ago in the Lancet of a study that was performed in China with 3 patients already also receiving in vivo CAR T-cell therapy. I think it's fascinating not to take the cells out, to transport them to a certain center, to do these, to actually incubate the cells, genetically modify them and bring them back, but to do this in vivo. But the issue is that there are 2 strategies to do this. One is that you use a genetic vector, and that you have to imagine this is kind of a virus infection that you induce, and you have to make the virus only to infect the T cells. So you have to modify your virus, and I think at the moment the issue is that the specificity of this infection is not completely. So you still get some infection of other cells. And we don't know how many of these cells, and we don't know what's happening with the cells. So that's one. The other strategy is you use small capsules, lipid nanocapsules, and you put the RNA, which is encoding the new receptor, in this capsule. And you inject the capsule, and you make the capsule to target only T cells. This is probably safer, but it's probably not inducing long-term expression of these CAR T cells. So I think the field is kind of split. One part is using the viral vectors, trying to increase the specificity of the infection in vivo, and the other ones are using these lipid nanocapsules and trying to improve the persistence of the CAR T cells that are generated. We are believing more in the lipid nanocapsules, and we're working on that at the moment.
Okay, thank you very much. And the very last question concerning the accessibility for CAR T for patients. Because let's hope that for myeloma patients next year we'll have it under reimbursement in Poland. But what are the experiences in Germany and UK, I would like to ask, concerning the clinical centers? How many clinical centers in Germany and UK has now experiences in CAR T, and do you think that this, I don't know, is there any kind of model of building this network of clinical centers to make it as accessible as needed for patients? What do you think about that? What's your opinion?
So in Germany, all the centers that are doing CAR T-cell therapy have to be certified. So we have to have SOPs.
How many do you have it?
So we have about 45 centers that are doing CAR T-cell therapy. Actually more that are doing lymphoma than myeloma. Myeloma is, I think, about 30. And I think in lymphoma we do about, in the whole Germany, about 700-800 patients per year. In myeloma, about 1,000 patients with CAR T-cell therapy per year. And these centers are certified, so inspectors will come see whether all the SOPs are in place, whether we have all the specialists, the infectious disease specialists, the neurologists, the intensive care unit, that they're all kind of in the loop, that they are participating, that they are trained. They will look that all the patients, when they get certain complications, that they get all the necessary diagnostic and treatment strategies, that we have the drugs to treat the complications available on the ward. And so this is regularly happening. Every 2 years the centers are kind of certified. And we also had centers that actually were closed because the inspectors had the feeling that they were not having all the SOPs and all the infrastructure in place.
Okay, how about UK? Could you share us some numbers from your country?
Yeah, so we have a very similar system in terms of having approved CAR T centres that are very heavily regulated. We have a similar number, I think about 40 centres in the UK that do CAR T cell therapy for lymphoma and the leukemia approvals as well. Fewer centres do myeloma CAR T because at the moment we only have access through clinical trials and through private healthcare, which is a small proportion of the UK population. But hypothetically, all 40 centres would be able to do myeloma CAR T treatments if this were to be NICE approved. I think it's just worth maybe saying that although we in the UK often feel like we are hard done by because we do not have access to CAR T, actually, to my knowledge, the only places in the world that have access to CAR T are America, Germany, and very recently Spain, kind of regularly outside of clinical trials for large... Switzerland and Austria, okay, I apologise. But it is not so many. So although we are desperate to have access, as you, I'm sure, are as well, we are, there are actually very few places where this is available.
Professor Gil, the situation in Poland.
In Poland, we do have 15 certified centers, but there are a few centers on the way to be certified. Up to now, we did treat 480 patients with lymphoma and 80 patients with acute lymphoblastic leukemia. So 2 centers are pediatric centers only, so only for ALL, acute lymphoblastic leukemia. So the system is the same, certified center must be.
How many centers shall we expect from myeloma if reimbursement is given the same?
So I think that most of centers for adults are would be certified. Most of. I'm not sure if all of those centers, but most of them.
So it's going to be 10 to 12, yeah? 10, okay. Well, thank you very much. We have 1 minute left. If you have any question, jeżeli Państwo macie jakieś pytania do panelistów, to bardzo proszę, jest okazja, żeby się dowiedzieć, jak to robią w Niemczech czy w Wielkiej Brytanii, ewentualnie o coś. Bardzo proszę, jest pytanie.
Ja
już
podbiegnę.
Michał biegnie z mikrofonem, także bardzo proszę.
Roman Słomkowski, pacjent. Po polsku, po angielsku?
Proszę mówić po polsku, spróbujemy wytłumaczyć.
Okay, we will do it in another way. I would like to ask you, where is the field of transplant? I know that CAR T is excluded in this procedure, but when you talk about bispecific therapy, is it also transplant included or not?
So in the UK, autologous stem cell transplant is still our standard of care for newly diagnosed patients after induction therapy. We are still recommending autologous stem cell transplant for all patients who are suitable, who are young and fit enough to undergo autologous stem cell transplant. I don't think anybody in the UK is recommending allogeneic transplant at all for myeloma.
If I can add, in Poland we are doing the same, so auto is standard of care and will be, I think, for the next couple of years standard of care. We are expecting for the CARTITUDE-6 study results when there's a comparison cilta cells, so CAR-T versus autotransplantation, and that will change everything. We will see how it comes, but so far still this is the standard of care. Allogeneic is performed in certain situation, in certain patient population, but it's not considered as a standard.
Yeah, currently bispecific antibodies are in second or third line, and transplant is in first line. But there are several trials now using bispecifics already in first line. And for example, I think in the UK you have a study, in France they have a study. I don't know about
We have Majestic 7, so
yeah. So also you have a study, and in these studies it's a combination of transplant plus autologous and a bispecific antibody. And we have a study where we use bispecific antibodies before and after stem cell transplantation. And the newest strategy now is to use bispecific or trispecific antibodies first line without transplantation, but that is still to be explored.
But in lymphoma setting, it's completely different because I must say that in patients treated with CAR T-cell therapy, so this treatment replaced autologous transplant, especially in second line, but we do more allogeneic stem cell transplantation in this population of patients, especially those who relapse or progressed after CAR T-cell therapy and they achieve a response. So this is completely different area in this field.
Okay, thank you very much. Thank you very much. We are running out of time, so I would like to thank Dr. Pawlin, Professor Einzele, our guests, and also Professor Gill and Professor Ditfeld for excellent discussion. Thank you very much. I think that we convinced all of you that I think that we convince all of you that CAR-T will open the new possibilities and new chances for patients also with myeloma, and let's say that soon it shall become the first choice number first as we begin. The first choice for treating. Thank you very much.